today we have the, as usual, we're going to go over the IHI curriculum, and then we're going to do the second part, looking at staff morale, the project improvement, and then have some didactic, interactive materials with the Just Culture with Natasha Green. And I don't know if people have seen, just before we launch into this, I just wanted to mention a couple of things about the interesting information that's coming out of the Delta surge here. One is that, and you may have heard this, is that there's been a demographic shift. Well, elderly still continue to bear the brunt of the Delta virus, in terms of mortality and morbidity. We're seeing younger and younger patients now, such that children are starting to fill the intensive care units in these surge areas of Texas and Florida. So I think it's one of the talking points about not, to staff, particularly those that have children, is to reveal, or at least, help them understand the information that the Delta virus is disproportionately affecting younger people, and that the highest hospitalization right now is not amongst the elderly for COVID Delta. It's actually amongst the 30 and 50-year-olds. So that's, like I say, a demographic shift in age groups, which may disproportionately represent, nursing home staff workers. Okay. Does anybody, well, before we start, does anybody have a comment or any additional information about how Delta virus is impacting them?
Dr. J, just out of curiosity, do you think the shift could be related to the fact that there was a larger group of the elderly population that were vaccinated opposed to that 30 to 50 range?
Well, I mean, it would be speculative, but certainly I think a higher percentage of vaccinated older adults is one contributing factor. And conversely, the under-vaccinated of the younger groups, for one, but also just the infectivity load. So, a lot of viruses, if you get 100,000 particles versus 1 million particles, by breathing the air or whatever, your exposure is, probably can make a difference. And I think part of the issue with the Delta is that there's just much more particles in the air per given sneeze, cough, or I don't know if you remember, we talked about the P words, when you, that sprays a lot more particles out. And so that's part of the reason why you want to wear masks, because, you exude these particulate matters, and everybody does that in normal conversation. So that and that's why they have those, 15-minute windows exposure to people, because the longer you talk to somebody face to face, there's a progressive scale of particles that are bombarding you, and the masks are supposed to retard that, and they're not 100%. So everybody that complains about them, but they are pretty effective, and for the surgical masks, they spray the particulate matters backwards, right? So they get that front forward exposure as well. But just remember, if you're standing behind somebody, and this is important for staff, you should not have staff behind each other if you're having a huddle. They should be in a circle and facing each other in a circle rather than behind each other. That's just one common technique there. A few other questions. Thank you for this. April's asking, have you heard anything about when the vaccine will be available to children? I have not. We can certainly look and see if there is any updated information, but I'm not aware of any CDC or even any speculation about that. I do know that the very, very high likelihood that come September, the FDA will fully approve the mRNA vaccines. So they'll be official, rather than under the emergency service there. Okay, I don't know if there's any other questions, but why don't we go ahead and move on to our IHI curriculum and the questions that we're posing here today.
Great. As always, we have some food for thought prior to the video. So we'll go ahead and go to the first slide, please. I want you guys to think about how do you determine what information is relevant to your staff and how they're going to retain that information. If you're talking to a staff member about something that doesn't compute to them or is not relevant for their particular situation, chances are they're not going to retain that information because it's not important to them. So really think about how you find out what is relevant to that staff member and how you're going to communicate information. Go ahead and go to the next one. And then what format do you use to present information to your staff? You know, when you study adult learning just in general, there's multiple different ways that people actually retain information. And so you really need to get an idea from your staff as you're talking to them what way is going to work best for them. Is it actually doing something? So, you know, a lot of groups I'm working with now, they work on hand hygiene. And is it good to show that checklist of what all you do to make sure that you've done hand hygiene appropriately? Or is it better for them to actually do it with a return demonstration where they're actually acting it out to ensure that it's good? Is somebody like to read an article, or would they rather see a graph or a chart so it's at a glance? Me personally, I would work out off of an outline more than I would like to read a research paper, because I like the high points, and then I'll make my notes on detailed things that I may need. And so everybody does things differently, and trying to figure out where that sweet spot is for your staff overall. In relation to that, how do you know if they've retained or understood the information that is presented? In quality improvement, we talk a lot about auditing and monitoring what interventions you put in place. And so if you've done a training or education with the staff, how are you ensuring that they know that information? And if we think back to phase one, we kept talking about the 5 attributes: who, what, when, where, and how. And those are the questions that you're going to ask the staff about a particular screen or particular process. I think we use the example of screening in phase one. So who does it? Why do they do it? How do they do it? What do they need to do it? And when do they do it? So if they can answer those questions back to you, then they've retained the information that you've provided. So you can always reference that too. And the next slide. And lastly is, do you model transparency in routine practice? Do you take a step back and give your staff all of the information that is relevant, of course, to them, and become transparent? This is key to building trust with your staff. And in this time that we're in right now, when there's so much misinformation and just the abundance of information, it is ever more important to be transparent with them. With the vaccines, when they initially came out, we had a surge of folks getting vaccinated. And then now that people are starting to test positive again with the virus, with the vaccine, that's a lot of the response I'm getting from people. Well, you said the vaccine was going to keep me from getting the virus. And that wasn't the case, but that's just an example of why you need to be transparent up front, because now you've broke that trust with the staff, and that they're aware during this pandemic that things are constantly changing. New data is coming out. And so things may look a little different, but the message is still the same. And then, is transparency part of your culture? Is that something that you've incorporated into your routine? Anybody have any questions or comments before we go to the video?
Hello, my name is Dr. Leslie Eber, and today we're going to talk about the most common questions about the COVID-19 vaccine now. These slides were developed by myself, Tara Rouse, and Erin Vignier. So it's really important that COVID-19 vaccine education is relevant, responsive, and dynamic. People don't want to hear the same information over and over. That doesn't help anybody move towards vaccination. And so it's really important to keep things fresh. So let's get started. Here are the most recent common questions that we hear about the COVID-19 vaccine. We had our original set, and then these questions come most recently from staff, family members, and residents. I always review about vaccine safety and efficacy and why it took so quickly to be developed. And then we'll go and touch upon these other questions as well. Are the COVID-19 vaccines safe? And we have more knowledge now. It's important to remind everybody that the FDA has had standards for vaccines for decades, and not only were those standards not changed for the COVID-19 vaccine, but they were elevated. The COVID-19 vaccine was authorized by the FDA and the CDC, and they have monitoring systems in place to continue to look for any safety signals for the COVID-19 vaccine. And we know that these systems are working because we saw them in action with the Johnson & Johnson vaccine. So this shows us that our system is working. We're going to also talk about the Johnson & Johnson vaccine in terms of safety a little later on. It's always also really nice to provide people with some hard data. And so this information comes from the medical letter, and feel free to copy this chart and share it with your staff and residents and family members. It talks about the overall effectiveness of the vaccines that are available in the United States, as well as for severe disease and preventing COVID-19 death. Now, how were the COVID-19 vaccines developed so very quickly? This unnerves people and makes them pause. And most of the reasons were that we had a global effort, a single-minded effort with all scientists working on this one task to develop a safe and effective vaccine for the COVID-19 virus. We had almost unlimited resources, money, knowledge, manpower, and technology. And we also were able to start producing vaccines even before we knew we could use them. So we wouldn't have that lag time to wait for production to catch up once we knew a vaccine was safe. Why should we trust the COVID-19 vaccine? And this is still a question that's on people's minds. It's keeping them up at night. It's important to remind people that the FDA is using the same strict standards that it has for decades, and no steps were skipped in development of the COVID-19 vaccines. It's also great to remind them that it's not just one voice that we're hearing about trust for the COVID-19 vaccine, but people are now very familiar with the ACIP and the VRBPAC. These are two independent committees who also reviewed all the data and safety for the COVID-19 vaccine. These are scientists who have no conflict of interest. And so we have many voices telling us we can trust the COVID-19 vaccine. It's also helpful to point out that all the people talking about the COVID-19, most of them have also received the COVID-19 vaccine. So we trust it so much that not only did we receive it, we let our families as well receive the COVID-19 vaccine. How quickly and how long will we be protected from the COVID virus with the COVID-19 vaccine? It's important here to be really honest and tell what we don't know. And we really don't know how long our protection will last. We really want to remind people that these are ongoing studies and trials that we're continuously looking week after week to ensure that protection is continuing. And on last report, we know that the vaccine lasts for at least 6 months, but not only for 6 months. And so we're continuing to look at this, and we may need booster shots. And the good news is that these booster shots are already being developed and tested. So if we need something, we're going to have it. It's also important to review the most common side effects from the Pfizer, Moderna, and Johnson & Johnson vaccine. These are the most common side effects that we see with all vaccines. And it's really important to be honest about these side effects. We don't want people to not understand what they should expect. At first, for the Moderna and Pfizer vaccine, there was a lot of talk about anaphylaxis. No, not so much, but it's also important to say, gosh, anaphylaxis does not seem to be very common with the Pfizer and Moderna vaccine, and you see that these statistics below. So now let's talk about the Johnson & Johnson COVID-19 vaccine and blood clots. On April 13th, 2021, the CDC and FDA paused the Johnson & Johnson vaccine because of reports of thrombosis. And this was called the thrombosis with thrombocytopenia syndrome, TTS. On April 23rd, the ACP stopped the pause because they had enough information, they did their due diligence, and they decided that the safety of the Johnson & Johnson COVID-19 vaccine was appropriate to offer to all people. And then they added some information for women between the ages of 18 and 49. So everybody would be on the same page. Here are the risk factors. It's important to know 1.9 risk factors per million doses. For women, it's 7 per million for women under 50 years old. It's important to explain if people are getting the Johnson & Johnson vaccine, what are the symptoms we're going to look for. But the key message here is the risk of getting a blood clot from a COVID-19 infection is far greater than the risk of getting a blood clot from the Johnson & Johnson vaccine. Is the COVID-19 vaccine safe if I am taking it when I'm pregnant, going to become pregnant or lactating? And now we have really a lot of data out, and we know that it is safe to get when you're pregnant or if you're lactating. And the American Association for OBGYN has also weighed in on this, and they have endorsed that it is safe for women to get the COVID-19 vaccine if they're thinking about becoming pregnant, are pregnant, or lactating. And what about sterility? I hear this a lot, and it's a lot on social media. So it's important to answer this question if there's any apprehension. Right now, there is just no information or data that shows that the COVID-19 vaccine would affect sterility at all. And so this is really reassuring. There is a lot of misinformation on social media, and it's important to share what we know right now. And what about the variants that we know right now? So the Pfizer, Moderna, and Johnson & Johnson COVID-19 vaccines have been shown to produce protection for all the variants of concern. In fact, the World Health Organization also just published that these vaccines, indeed, from their perspective, are also very effective for all of these variants. Now, we may get some new variants, and then we'll have to do further testing. So we're still learning details about how much protection each vaccine will give new variants, but it's really important to reassure people for what we know now. And right now, the vaccine is incredibly effective for all the variants. Do we need to get the second dose for the Pfizer and Moderna COVID-19 vaccine? Is it really needed? Yes, it's really needed. So our studies show that the first dose of these vaccines can give somewhere between 63 and 80% protection, but we really want the full deal. We want the 94, 95% protection. And so it's really imperative that everybody get their second dose. And it's important to be really honest with people that we haven't really studied a one-dose scenario. We don't know if you just get one dose of the Pfizer or Moderna vaccine, how long will that protection last? Will it wane sooner? We really don't know. So we really want everybody to be fully protected. And now these are some action steps and some discussion questions that I hope you'll be able to go over with your cohorts. I thank you so much for your time.
Very good. So before we move to State Morale, just to get back at the question of the rollout for the vaccine, COVID vaccine for children 12 and under, I was just exploring the CDC website, and they're fast tracking the studies. So that means that they're have an accelerated window by which they're doing this, but they did not give a precise date when it's going to be approved, if it will be approved. So that's the update on vaccines for 12 and under. And just as a side note, that 15% of all hospitalizations for COVID constitute children 12 and under. So, all righty. So we move into staff morale. We have some presentations from our collaborators from nursing facilities, as well as from Natasha Green from QA. So do you want to move ahead with that?
Cindy is joining us from Wish of Living Center today and has provided their PIP. So Cindy, do you want to just go through what your process has been and what you have been finding so far?
Sure. So we decided that we were going to do a survey, and we did all of this basically since last Wednesday. We passed out the nursing home employee satisfaction survey that is given to us by CMS. And I picked 20 people in our facility and asked them to return it that day, which we did receive 18 of the 20. And then I was able to sit down and do face-to-face with 10 people and talk to them about, I actually used the questions and talk to them about their experience here at work and what matters to them. And then we kind of sat down as we picked all of our department heads to be our squad members. We definitely identified in our survey that staff morale is our problem in our facility. And basically things have changed so much since COVID. We don't have that team anymore that we used to have. Everyone talks about how we wish we could go back to those days, because we've always been a really good facility in North Dakota and worked as a team, and we don't seem to have that anymore. We have had turnover in staff. We have a lot of new younger people. We have had some of our major department heads retire during COVID, which made a big difference. And everyone's busy and everyone's lives have changed. And we decided that we need to get that back. And that was the thing that most people talked about in the face-to-face is they want that back. They want that feeling back in the building. The atmosphere is different here. So we decided that we were going to work on getting that back into our building, and we're going to be doing that, hopefully. We identified that teamwork and communication is a problem in our facility now, and that we're investigating, as of yesterday, team building exercises, possibly bringing someone into our facility to work with our staff, and maybe working on something monthly, possibly a short 3 questionnaire going out to the staff, and we're going to be working on that. We just need to meet again, and we are reaching out right now to a couple people and asking if they would think this would be something they could do in our facility. So that's what we're going to be doing.
Sorry, I was muted. Wonderful. Cindy, thank you so much for sharing that. Sarah, if you want to click to the next slide, this kind of just shows the PDSA steps that Cindy just kind of went over that they have done over the last week. And I'm thrilled to hear about your focus on this, on team building and that, and would love to just, we have one for sure, more session that I know that you will be available for, that won't be at convention. So, you know, if you're able to make progress on this by next week and can even, you don't have to send something in, if you can just share with us how that's going and what you're finding from those 3 questions, and that would be great.
Okay.
We did have a couple other facilities that sent in bits and pieces, and there's steps that they had started working on with their PIPs. One was Cheyenne Care Center in Valley City, and I just reached out to them. They also used the CMS survey and had started on that process, and aren't quite as far along. Cindy is our, overachiever, go-getter. It's all that's going within a week. But one of the things that Amanda had said when I reached out to her was just that they have added a question to their staff rounding. Amanda, if you're available, if you wouldn't mind just unmuting and just sharing that little bit of one of the things that you had already had done to help with this, that would be great.
Cindy, can I ask you a quick question? When you were interviewing the 10 employees, did they have any ideas of how to change the teamwork and communication? Any suggestions?
Honestly, no. No. Seriously, I did a lot of this work this week because we're in the middle of, we had a catastrophic event happen in our facility, unfortunately. And we have all of our staff working together to get over it, and also compiling things. And don't you know, 20 minutes before we got on today, the state walked in. So everyone's stressed out. We have been having meetings with staff. Hopefully after this is over with, this exercise is going to be a good thing for us to pull us all together. It's what we need.
And Cindy, even if you just ask him, I know that we had that joy in work presentation not too long ago, but just if everybody could just make one recommendation of what brings you joy when you're at work.
Oh, I did ask them that question. I asked all of them what brought joy to them, and almost every one of them said caring for my resident, that my resident was happy. It was all about the resident. And seriously, we didn't think that would be the answer. We thought it would be, we thought most of these questions were going to be relating to pay and to working short. And they did not. It was all about the residents.
That's awesome. And really, maybe consider doing some kind of brag board. I know I've said brag board before. I was a fan of brag boards. In your like employee break room or something that says, hey, Miss Jones has, maybe she did something good in therapy, or maybe she recovered from a UTI, or whatever the case may be, but it's presented in a way related to due to all your hard work and dedication to your residents. This is what Miss Jones has done. Kudos team, kudos Miss Jones. And if you just keep them in there, then they constantly see, wow, I'm making a difference in their lives.
Okay.
I absolutely love that. And the fact, if you can get your staff, solicit from your staff what positive things they have seen with the residents and have them responsible for bringing that out, that might just help that staff morale and staff teamwork. I think that's a great idea, Kelly. Thank you so much.
Yeah, and maybe Cindy too, we talk about rounding all the time. Let's add something to our rounding checklist. But if one of the questions to the residents is, can you please tell me something that a staff member did today that made you happy? And then include that on the brag board too.
Sure.
Ms. Jones said you made her smile today because you played her favorite song or whatever.
Yeah, and I would add from a medical director's perspective that it would be, I think, useful if the medical director or the physicians or providers, nurse practitioners that are visiting and evaluating the patients, whether you can get feedback from them regarding their clinical impression of whether somebody improved or not, or what gains they had, what successes they may have had. So a classic example is that we de-prescribed a medication, and Mrs. Jones woke up. She's more active, So, you can actually approach it with your providers and just ask them, regarding any de-prescription action plans, whether, whether they saw a change or not. And actually, no change may be a good change, right? Or maybe a good thing. So that, for example, if somebody that was on antipsychotics and you stopped them and their behavior is the same, that's actually to be celebrated. You got rid of a dangerous medicine. So you can use that perspective. And certainly, when staff or pharmacists, makes recommendations along those lines, those could really be, like, say, celebratory episodes. So I just want to comment here. I'm trying to read the thing here. Linda was talking about one thing from our surveys that was indicated that they didn't feel that they had valued input at times. Common comment we hear is that there's no teamwork and lack of supervision on weekends, holidays, evenings. They also stated accountability is lacking. Yeah, so Rhonda, do you want to, are you able to comment a little bit further on that?
Yeah, this is Rhonda from the Cheyenne Care Center. I work with Amanda. So when we did our surveys, this was a few of the things that they had stated, is that we don't have the same teamwork that we used to have. Same as you, Cindy. They feel that it's more, everybody just works individually now to do their own thing and then they're done, which doesn't, give them the support that they need from their other staff. They also said that they don't feel that their input is valued at times. And that one kind of puzzled us, because I always have an open door. Please come talk to me, give me your inputs, because I always say I can't find the answers for everything. I need your guys' help. So we're going to explore that a little bit more as to what do they mean by that their input isn't valued, so that's one thing we're going to look at. The other thing that they said is accountability is lacking, which we have identified at our facility. It's not that we don't hold our staff accountable, but what we are seeing here is that because of our staffing issues, the lack of, sometimes it's almost like our staff know that we're not going to fire them. I'm not saying that we don't hold people accountable, but we've heard, several times that, well, before, if that person did that, they would be let go and things like that. And that's not such a luxury anymore, because staffing is so hard to find, and travel staff, you don't get much help from them either. So they really say that accountability is lacking, and that has really affected their morale, because they see staff that, maybe are coming in late all the time, or leaving early, or taking longer breaks, or, not charting and things like that. I mean, there's, so we're trying to work on positive accountability in that way to kind of try to bring that back, because we do have to work with what we have and grow them, and hopefully they'll learn what we are expecting and what's needed. So we looked into that. One thing that we added to our walking rounds, like Amanda was saying, is that we ask at the end of the walking rounds, what do you feel is working good? What do you feel should be done different, to kind of get more of their input, to make them feel more valued and, with the care of the residents. So those are the kind of things that we're seeing too, but the lack of the teamwork, it seems like, they're just kind of working for themselves and want to get their job done and go home as soon as they possibly can. So those are some of the things that we're working on. And we do have a morale team here at Cheyenne Care Center. We have a group of staff. There are no leaderships, like no administrative, like no coordinators that are allowed on the morale team. It all has to be like the direct line care staff and whatever, so they can put things into place to, you know, increase morale as to what they see it as. So they've been amping that up more and more too, to hopefully, you know, increase morale. But it is a struggle right now. As we knew it before, it definitely has changed. After COVID, it did a lot. So, yeah.
Yeah, that's excellent insight. You know, and I think what the recommendations are for the morale team, you know, it's like mushrooms came to my mind when you said morale. I said, you know, I think morale mushrooms, right? But the morale team, as they make proposals, make sure you convert that into a PIP, you know, and small tests, small changes. The other thing, just as that you brought up, Rhonda, was this whole question of, I think, acknowledgement. And so when you do the structured walk rounds, it's very valuable to either use a 3-5 card or to use, you know, you can get an iPad and, you know, cursor script it, but to give a receipt, you know, to somebody, so that, you know, maybe by the end of the day, that thank you card that says thank you for your suggestion, and you give that to them, and that acknowledgement will do a lot, you know, to address that whole issue about, you know, valuing people's input.
You know, I think that we are. Oh,
Sorry, I just want to say something quick about that.
Yeah.
You know, we've had people who've retired through COVID, and one was, and my schedulers that I have now, they're amazing. Don't get me wrong, but I have heard several times when we have been talking to people and about the thank you note, that our scheduler prior, you know, before she'd been here like 30 years, she used to hand write thank you notes to staff when they would pick up shifts or work a shift that wasn't theirs. And you still hear that now, and they're like, oh yeah, you know, Claudia used to write us notes that said thank you for, you know, handwritten, and would sit. So, you know, those they go a long time. So that is something that I am going to be implementing with like my nurse managers and my nurses, you know, and hopefully my CRA supervisors will do that with their CRAs, to give them that, because it resonates for years and years when you get a handwritten note thanking you for your input or going the extra mile.
Yeah,
that
exactly.
is great. I think all that you were just talking about, Rhonda, and has been coming up in chat, fits perfectly along with our next topic, which I want to make sure that we get to Natasha here to talk about just culture. That fits in ideally with what we're talking about today. So if we can move on to that next.
All right, thank you, Michelle. Well, hi everybody, I'm Natasha Green, and I work as the Quality Improvement Program Director at Quality Health Associates, who works as a subcontractor for the Great Plains Quality Innovation Network. So thank you, Michelle and team, for inviting me here today to talk about just culture. And today I'm really going to be talking about just culture, and really, again, how it relates to staff burnout, how it can be used to help improve that joy in work and be used to facilitate some of that team building, and how it's an essential concept when it comes to your team and your staff buildup. Next slide, please. So joy in work impacts staff engagement and patient safety. And you really can't have a culture of safety without implementing some form of just culture. And when we look at just culture, we look at the fact that people make errors which lead to accidents, which we know lead to deaths. And typically, or historically, the standard solution was to always blame the people involved. And if we find out who made the errors, and if we punish those people, we solve the problem. But what we've come to find out is that's not the solution. That's wrong. The problem is seldom the fault of the individual. And what we've come to find is that it's the fault of the system design. So if we change people and punish people without changing the system, the problem will continue. And we break down that structure of joy in work. We break down that trust that we build. So we need to try to use just culture to help us restore joy in work. Next slide, please. Just culture is not a blame-free culture, and it's not a punitive culture. It's something that we like to call in the middle. It's an accountability culture. And the goal is that we want to get to a joy culture where you have forgiveness and equity, so staff feels safe. And by doing that, they feel happiness because they don't feel like if they make a mistake that they will be punished, and they enjoy their work more. So we want to focus on creating safe, human places for people to find meaning and purpose for their life and for their work. Next slide, please. Just culture uses understanding of the human fallibility and human behavior, and then it takes that understanding to design systems for reliability, to compensate for human error, and to understand human behavior to avoid those choices from being made. And then it always supports a culture of learning. Next slide, please. We know that even though we do design systems to do the best that they can do, we need to still have that accountability piece. So just culture also ensures that humans are accountable for their behavioral choices. And we'll go over those here in a little bit. So we respond to errors depending on the behavior and the choice. Next slide. So there are 3 behaviors that we can expect. There's human error, which is that slip, lapse, or mistake. There's at-risk behavior, where the individual feels like their choice or their decision is justified. And the example that I use for at-risk behavior is, let's say you're driving on the road and you speed a little bit over the speed limit. I know many of us say, oh, it's okay if you go 5 miles or 1 mile over the speed limit. And we justify it because we become comfortable with doing that. We say it's safe, it's okay, the cops won't pull us over if we just go 5 miles over the speed limit. But technically we're breaking the rule, we're not following it. So in the just culture world, we call that at-risk behavior, and we try to understand why. And the last one is reckless behavior, and that's that conscious disregard of a substantial and unjustifiable risk. And so that's knowing, hey, I have an incorrect sponge count. I'm going to continue to close on my patient and not figure out why I have an incorrect sponge count. I'm just going to disregard the substantial risk that I see in front of me. Next slide, please. So with just culture, we understand those behaviors and we come to a common understanding of how to treat people when things happen. So that creates that safe culture, that safe space, which then translates into that joy in work, that reduction in staff burnout, because they don't feel like they're being penalized for every little mistake that they make. Next slide, please. Now, since we have are short on time, I'll just summarize this video instead of playing it. But this is a story of a nurse who made a mistake. She had a patient who had diabetes, and her blood glucose machine was showing a high blood glucose, so she kept giving insulin based on the sliding scale that she had available to her. She continued to follow that order, check the blood sugar. The patient kept saying that they felt that their blood sugar was high, but then patient became critical. A care team came in for a rapid response. They found that the blood sugar actually was low. So what happened was that Annie was penalized for that. She was put off of work for a couple of weeks while they did an investigation, and she reported that the machine did say hi. It said hi. When they did their investigation, they found that there was an error on these machines where an alert was popping up in front of the blood sugar. So if you didn't close out of this alert that was a generic message, it would say hi. And so a nurse could make a mistake, read that glucose machine and say, yep, that does say hi, and interpret it incorrectly. And so instead of reading low like it should have, she saw high and gave insulin and caused an error and caused the patient safety. And because the facility implementing just culture. They apologized for how they initially responded to me, and instead of penalizing her, they coached her and they consoled her because it was a human error. It was a system flaw. It wasn't a personal flaw. And Annie describes how she felt through that process because she didn't go into healthcare wanting to cause harm. And she felt awful, absolutely awful when this mistake happened. And she felt better when her organization consoled her and took the steps to make sure that this wouldn't happen again. Next slide, please. So here's how we take accountability for our behavioral choices. So in Annie's case, if we would have worked through the complicated algorithm that we do, we would have came through the human error. And to manage human error, we would have redesigned processes, procedures, and provided training to staff. We would have said, this is not a person issue. This is a product of our current system design. So how do we simplify that? We console the employee and we reevaluate. We do a performance improvement project and we reevaluate our processes. The at-risk behavior, our speeding a little bit, we would manage that through removing incentives for at-risk behavior. We need to do a root cause analysis and understand, why are the staff choosing to do that at-risk behavior? Are staff members skipping hand hygiene? Are there opportunities for us to increase incentives for healthy behaviors, like putting machines outside of the door so they can perform hand hygiene more easily? And then we increase situational awareness. We coach those staff members. And then with reckless behavior, that's the traditional method that we would always do with any error. And that's where we have remedial action or disciplinary action. Next slide, please. So I'll go through this quickly, but we have human factors, and that's a big part of just culture and creating joy in work is redesigning those system processes. And we need to understand why people make mistakes in order to design the process to improve it, so we can include that. Next slide, please. So some factors that impact performance, I won't go through all of these, but typical ones that we can't change the way that our staff members come into work with us, but we can design systems and processes to kind of mitigate those from happening. So they may come in with fatigue, illness, boredom, frustration, stress, or having a lot of handoffs may cause issues or unnatural workflow, and we can help create processes to adjust with those items. Next slide, please. So we use what are called error reduction strategies to help with those processes to redesign. So we avoid resilience on memory, we simplify processes, we standardize things, and I've heard a few of these already. We use protocols and checklists to help improve those processes and decrease lookalikes, soundalikes. And these are all things that you all can use on your performance improvement projects. Next slide, please. Normally I do a case study and I kind of ask the team, but I know we only have a few minutes left. But with this case study, I will just say this one is one where, again, we had a human error. So I normally would ask, what could have been done to prevent this error? Is there something that in your healthcare facility you could have done to help prevent this from getting to the patient? And I usually say, post it into chat if you have ideas, but this one's with an infant who was given the wrong medication. And it was Lanoxin instead of Lanoxone. And do you think that this person who gave the wrong medication, do you think that we would have consoled them, coached them, or disciplined them? I see one that said give the diagnosis for the med. And with this case scenario, and just because we're short on time, this person was human error. They did make a mistake. And so normally what we would have done was to console the employee, figured out why did this happen and what opportunities do we have to ensure that this doesn't happen again. Do we have prompting in the EHR? Can we scan the medications? Is this a lookalike, soundalike medication? Are there ways that we can prevent that so that way they're not grabbing that medication? Is it in a similar spot? But again, we don't want to punish the employee, but console. So next slide, please. Lastly, there's a learning culture. So again, we just see events for opportunities. We look at the systems and we identify risks for behaviors or opportunities for our processes to improve. We investigate the source of errors and at-risk behavior, and we redesign those systems to reduce the risk.